Yeah, I'm Lou.
Just curious.
Thank you.
All right, we're going to call the council to order. I'll get into the details. First, I hope everybody had a lovely Thanksgiving. Hope everybody is getting through the holiday season and enjoying it. We have a couple new people to add, and we want to welcome them. We want to recognize Lou Jikusha, a new cybersecurity appointment from the AG's office. Like to add anything? I ask you to introduce yourself.
Well, my name is Lou Jikusha. I'm very happy to be here. I'm faculty at Boston University and director of Health Informatics Program, founding director. I also have been dealing with cybersecurity. I'm a founding member of the Center for Cybersecurity and Reliable Information Systems that worked in 2004 with basically Department of Defense. We have been working for 20 years, cybersecurity, and also I'm a research director of cybercrime investigation and digital forensics lab. So that's my area. Thanks for this.
Yeah, sure. Welcome. I
Nice to
want to
meet you.
welcome though, is it Catherine or Kate?
Katya.
Katya. Katya Sharp, if you are not joining us permanently, you are just, I believe, standing in.
Just here this month, yeah.
But I'm sure at the end of 2 hours, you will wish that you were here permanently. So I'd like to have a motion to approve the minutes. We got it nicely in advance. This team is amazing. I appreciate it, and I know we all. Any additions, changes, corrections?
Chair, I just have one small little change, hopefully a friendly change in section 3 under the discussion that we were having around monitoring hospital financials. In the third paragraph, there's the second sentence describes Mr. Seltz suggesting great risk in identifying certain hospitals. I would just suggest a slight word change in identifying to naming. It was really the naming of hospitals that I had suggested. Just a slight word change there.
Any others?
Also one word just below. Ms. Peters concluded the discussion, noting that I would say, since there is some disagreement here, asserting that. Thank you.
Any others? Hearing none? Thank you. Thank you. Thank you. I'm going to have to read it. Oh, I'm sorry. We have somebody online, so I have to read. Okay, so both of you who are either new or sitting in, under Robert's Rules of Orders, you have a choice. You can either approve it or abstain. And I'm going to read your name, so you have to say I, Renee, or abstain. Okay. Not here. Cara.
Hi.
Thank you. Adriana?
Yes.
Thank you. Alan?
Yes.
David?
Aye.
Kathy?
Abstain.
Amy?
Yes.
And Jean?
Yes.
So approved. We have a lovely full agenda as always. And we have decided to put the executive director's report first to make sure that we have time. Often it's the last thing, and if somebody has something they want to add, they have to squeeze it in because we try to end on time. Then we're going to have an interesting conversation for those of us that are actually passionate about it, because we are starting to talk about oral health. And that is exciting. PBM, for those of you who have read the material that was sent out in advance, the chart was intimidating, but great and helpful. I think we have a very rich conversation about it. Priority areas, remember, we do this so that everybody in the council is informed, have a chance to ask questions, and really if somebody asks us about them, we can actually say the relevant and what we are actually doing. And then we will end up hopefully on time and maybe early, if possible. Unlikely, but possible. Great. Lauren. Thanks.
Don't mind pulling up yet.
Aye.
Well, I should first start by welcoming everyone, and a special welcome to those who have to join us. It's like we have a lot of a rich background that will be informative to both the council, but CHIA's day-to-day work. So as we've been trying to be better at including follow-up items from the prior council meetings, the one item I wanted to circle back with from last from the September meeting is around the Compare Care letter. So just as a refresh for some of our newer members, this council had recommended and drafted a letter to the legislature, to legislative leadership, recommending that legislative changes be made to strike a section in the CHIA statute that directs CHIA to host and maintain a price transparency website. And it came from a number of different considerations, but notably, it's a lot of resources for a function and a website that we've seen very little traction or traffic and utility, because it turns out people don't shop for their healthcare services in the same way that they shop for a pair of jeans. So that letter is still sort of with legislative leadership. I think I mentioned last time, it was positively received. There was not sort of any indication about timing or anything definitive, but we will continue to work with our partners in the legislature to hopefully advance that proposal in the coming year. Questions on that?
Sorry. What is the biggest expense with maintaining such a website?
I think the actual sort of having it maintained on the website is not necessarily the cost. The real cost is if we were to make this, to really get this out there and make it something of utility, and we have to launch what's more like a marketing PR campaign than anything else. And so that was where we saw the real cost. We looked at parallel initiatives in other states, and much of the costs were rooted in getting the word out there, driving people to the website, informing them how they should or should not be using it. So that was the bulk of the expenses. So I think the thinking or rationale was if we want to maintain this website and do it right, we really need to put significant multi-millions into that launch and that type of campaign.
Because in the commercial area, there is a need and demand, and there are companies like Insurify that are very successful from MIT. That it's a like 300 million startup that compares basically various insurance offers. I know that health insurance is different, but are we preventing something to the consumers based on that, or how do they select, just by the employer? Or
So
sorry,
yeah, it sounds like you may be talking about the process of selecting an actual product type or plan type, which I agree with you that is probably a more upstream decision point where some of these tools would be probably more beneficial. This website, or as it's laid out in statute, requires us to put out cost per service, like the average knee replacement, and for each different provider hospital in the area. And I think that's where there's minimal utility, because one, it's going to vary to someone who has deductible prices that posted price of that knee replacement is of course subject to a deductible, other cost sharing. So it's not necessarily reflective of what they were paying. I think the short answer is there's not currently statute or that I'm aware of existence that a tool to help folks decide between product or plan. But I think that the scope of this was really the website to display costs.
A complementary answer might be that there are so many different plans with so many different services covered and different out-of-pockets, even offered by the same insurer, sometimes to the same company, that it's proven, and they change over time. It's proven almost impossible to provide relevant and usable information about the price that sick people would actually pay when they sought care at different places. And also, knowing price is not very meaningful without also knowing quality, where the data are almost completely useless. And also there's the underlying question of whether you need the care. So I think asking patients to shop by price and quality is mainly a distraction and an excuse that lets people who should be containing cost off the hook from doing so. But there's obviously disagreement about it.
Right, right. My general concern will be if we remove the price, is it incentive for prices to go up because they're not reported? That's my main concern. When you compare, basically you keep the prices under control. Okay.
Yes.
That's it. But thank you very much.
So we'll keep requesting, we'll keep asking. People stop doing this. Keep us updated.
Will do. All right. Moving on to the next one, thank you. In terms of a budget update, we are working with ANF right now on CHIA's FY 2027 budget submission. We expect that to be filed in the governor's FY 27 budget. Keep me honest here, but I believe will be released late January of next year. And that really just kicks off the budget cycle process. We'll next go to the House and the Senate to later this spring, and hopefully we will have a budget by July 1st of 2026. But I think generally CHIA has no concerns. We're not making or requesting any significant modifications. In terms of legislative updates, so we've been really busy this fall implementing the various provisions that were included in the Market Oversight Bill and the Pharmacy PACT Act that were passed late last year. And so that's been sort of our focus of the last couple of months. We do continue to monitor a number of healthcare bills that are pending in the legislature right now, ahead of the second year of session, the legislative session, which typically is the most active and where we see the most debate. We are also supporting the legislature in conducting both prospective and retrospective cost analysis of mandated benefit bills, which are, if you're not familiar, legislation that requires health insurers to cover certain services or benefits. So as part of there's current statute that requires us to both do that prospective and retrospective analysis. In October, we published what we call our comprehensive retrospective analysis of all mandated benefits that are in effect here in Massachusetts, which is, so for the 59 mandates that we looked at, there is a marginal or added cost impact to premiums. We found that it was over $150 million. So it's not an insignificant number.
Are there many in the pipeline now?
Yes, so great segue. We are currently working on 2 prospective mandated benefits that we plan to issue early next year. One is with respect to required cancer screenings for firefighters, and the other pertains to cognitive rehab services for individuals with acquired brain injury. So we are working to complete those 2, and typically once we finish 2, we have another 2 in the queue that we'll get started on. So it's not an often not mentioned area of our work, but there is always work being done. We did want to just give a shout out to the HPC and another successful cost trends hearing that was held in November. The sort of central theme and title was working together to safeguard the Commonwealth's longstanding commitment to healthcare affordability, access, and equity. I got that right. And I would say much of the hearing was focused on the converging challenges of affordability and coverage protections amid some of the many federal changes. Primary care was another central theme of the hearings. I think there was general consensus that the system needs to not only invest more in primary care, but also really focus in on reducing administrative burden for clinicians. In terms of key takeaways, I think there was general reinforcement of this notion of shared responsibility, which is sort of has a longstanding tradition here in Massachusetts, and that really bold action is needed, and bold action in the of the kind where every market participant really needs to have some skin in the game, and there may be pain points for everybody, but everybody needs to come to the table. There can't be winners and losers. I think to some degree everybody needs to have both shared responsibility but shared pain, because there's a lot of tough decisions ahead. And I think that there was sort of general consensus around needing to come together, that sense of shared responsibility, but that the status quo was not sufficient. I don't know, David, if you have anything to add.
I think you covered that great, Executive Director Peters. I would just add, as always, I think there's a recognition and understanding that if any state can and embark on such a bold and comprehensive approach to reforming and moving away from the status quo, Massachusetts was well poised to do that. And part of that is the infrastructure that we have built up, and part in the data infrastructure that we have here at CHIA is a part of that infrastructure. And so, I think coming out of this, a sense of a call to action, recognizing the headwinds that we're facing, and we'll see where that leads.
So I did watch almost all of it, 8 hours. So first of all, the quality of the presentations, the Q&A was just amazing. It's always been amazing, but this one, I guess, especially given the circumstance, the quality was just really up there. But I would say, we're talking about sense of urgency. It's almost more than that. It's almost like this time, the level of seriousness is unusual. I mean, obviously, it's understandable given where we are, but I have to say there is, the sense, just to be very honest, is very heavy on consensus around urgency, crisis, but there's a little bit light on very concrete solutions, especially new ideas. There was a shout out for PACE. There was a little call for some kind of unified IT system. And there is some inkling on rate capping, which is not popular, but otherwise we're talking about the same things we've been talking about for a long time, like primary care and behavioral health. And so how do we, what is the next step, David, when it comes to very concrete things to realize the points that Lauren just made in terms of coming together and put some actions together?
Yeah, I share your reflection. I think we have a good set of what we know are some strategies. And I think part of it is finding the balance of how we pair some of these strategies together in ways that the different constituencies can live with and can have a grand bargain and have a balance of these different types of approaches. How do we pair, having real relief on administrative burden with having to tackle some of the underlying drivers of healthcare costs? And so I think part of that, I went to the Mass Association of Health Plan conference too, and that was a few weeks after the cost trends hearing, and Zeke Emanuel spoke there, and his suggestion was, throw everyone in a room and lock the door and throw away the key and don't let anyone out until they've come up with a plan. And so I think it's going to take some, leadership and some political will to kind of say, it can't be around the edges, and we can't, kind of go around each other and say, that's the red line that I'm not willing to cross. Because I do think we have a good universe of ideas. I really do. And I think it's about finding the balance of putting them together and understanding that, like we have in the past, that there's a public goal that requires collective action and collective sacrifice, that unless we do this, that the system is in real trouble.
Yeah.
And that there's not a big pot of gold that's going to bail us out. It's not coming from the federal government. It's not coming from state government. And it can't come from families and businesses in Massachusetts any longer.
Great, thank you. I would just say, on top of the ideas I'm just thinking, I think we need to aggressively expose the inefficiencies in the system. And so I think it's HPC and CHIA. I remember years ago, HPC did some really good work on post-acute care.
Yeah.
You know, now we're gonna tackle, pharmaceuticals. And then sometimes the stakeholders are bad guys and sometimes the stakeholders are good guys too. We need to, be willing to, put all of us on the stand, if you will, to look for opportunities. Because if we're not willing to do so, then we're just gonna be, to a certain extent, spinning in circles. And that is, to your point, a very different, larger environment. We cannot afford to sort of business as usual. Not to say we're going business as usual, but it's a really, really grave situation. So thank you.
Thank you.
I share the concern, but having also looked at this for a while, it's hard to imagine a politically persuasive story that leads us toward squeezing out the probable half of healthcare spending that's wasted and recycling it as that fat as clinical bone and muscle. In the absence of a politically persuasive story, I think we need to recognize that there are hundreds of people in state government and in a few other places who have increasing understanding of what's wrong and some ideas about how to fix it. But part of the difficulty is the fat is not like a slab of fat that you could carve off around a roast. The fat isn't even marbled like in a prime steak. The fat is interlocked into how we do business. And David, you alluded to that. We can't admit, Drew Altman, with his 50 years, admits or claims, agrees that we can't eliminate prior authorization because it'll raise health spending by 5%, according to one actuarial study, because we don't have alternative cost controls. So all the pieces fit together. And I've concluded that we're not going to fix it until, in Winston Churchill's words, he could always count on the Americans to do the right thing after we tried everything else. And in this instance, I'm convinced it'll take a crisis.
Well, we are in that crisis now.
This is I know many people would agree, most people would agree with you. I think this is like the storm front ahead of the hurricane. These are symptoms of the underlying unaffordability, inequality, and waste in healthcare. The crisis comes when Congress 5 years from now freezes Medicare and Medicaid, and if the ACA is still around, ACA spending. And caregivers look to private insurers to pay higher prices, and employers run screaming from the room because Boston University health insurance for a family next year will be $34,000. And that's a little on the high side, but so the private sector will say no. We'll have massive bankruptcies and denials of care. And then there'll be pressure for reform. But without a clue about how to handle or respond to a crisis, it'll be like the morning after Pearl Harbor, unless we prepare. And I think that that's a serious activity that state government should be engaged in under the heading of contingency planning or health planning. But that itself would require some political impetus and attention. Because you can't mix it up.
We shouldn't belabor this because we can stay here all day. I would just say, the Commonwealth has a choice, in terms of whether we treat this as a real crisis or just wait for another 5 years. There are people who are gonna die because they are no longer accessing essential services. And these people are very, very weak to begin with, right? So there will be people who lost in the shuffles. And then, so the question is whether we think that's just rounding error or that's a fundamental change to where we came from. And so there are some political sort of decisions that we collectively have to make. And then, we all have a voice. So anyway, so I hope to succeed.
Can I just, I can't raise my hand on here, so I'm not sure how to do that, but I just want to say that I think that folks are echoing a lot of the response that we got during the cost trends hearing from the different stakeholders, and to not, ignore the fact that there's ongoing work going on behind the scenes at the state, but all the different agencies working together to address this issue. So I just wanted to chime in to say that, especially from the DOI perspective.
A lot of people working on it, and we play an important role in being still the most respected information is provided to all. Thank you for bringing it up.
No, I think it's a good book. Reiterating and I think it helps for the council members to tie in our work and some of the contextual hearings and forums and discussions that are happening. Obviously, the cost trends hearing is, as it was dubbed from the start, the Super Bowl of healthcare, and you know, I think it's helped drive up drive up the urgency and reinforce the message that I think all of us are familiar with, but I think it's up the ante. Go to the next slide. Great. So this last item is just to provide some brief context ahead of tomorrow's release of the 2025 Massachusetts Health Insurance Survey. So for some of the newer council members, the MHIS is our biennial population-based survey that tracks key indicators across access, affordability, coverage, utilization, among several other metrics. This year's survey was fielded between January and April, and we've received responses from over 5,300 Massachusetts residents. In 2025, we introduced some new and as well as refined questions related to behavioral health and primary care, tax advantage health savings accounts, impacts of administrative burden on receiving care, medical debt, and we did some enhanced stratification on incomes so that we could get a better look at some of the access and affordability issues for not only the different income buckets, but the various insurance programs that are associated with some of those income categories. Some highlights from the survey include Massachusetts, not too much of a spoiler alert, but Massachusetts continues to lead in terms of healthcare coverage, but most residents, despite all high number reporting that they do have a primary care doc, a significant share are still experiencing challenges accessing and affording their healthcare. So the full report and survey will be released tomorrow. We are doing a joint event with Blue Cross Blue Shield Foundation, at which tomorrow morning we'll all be kicking off the event with a sort of review and highlight of some of the key findings from the survey. And that will then be followed by a reaction panel. So if you all should have received an embargoed copy of the report, I think earlier this week, and the details for tomorrow's event. But if you do not and are interested in either the report or attending, please let us know. We'll make sure to coordinate.
Thank you for sending that out. And if council members can go, I think it'd be terrific. Has the CHIA always done it with Blue Cross like this?
No, this is the first inaugural partnership. Perfect. So we are grateful. The foundation not only helped support the funding of our survey, but also has been working lockstep with us to put on this event. And I think we have over 300 people registered to attend.
Wow.
Is there a surprising finding, or is it pretty much the same as expected?
Good question. I think the finding, I don't know if this is new. I wouldn't say this is necessarily new to this survey, but the number just did jump out to me. When you look at some of the rates of medical debt, the vast majority of families that reported medical debt are those who incurred the debt while they were fully insured. Mm-hmm. And so that it's really points to the fact that coverage, having health insurance only gets you so far. Mm-hmm. So I would, off the top of my head, that is one that continues to jump out at me, but I can think of others. Yeah.
I have not read the report yet, but I will. I look forward to it. Just a question about whether there's exploration of regional variation.
In this report, We don't break it out by region. We do stratify a lot of the findings across different demographics, so race, ethnicity, income, age. I'm probably missing some. We don't get a region in this survey, but I think it's something that we should consider.
And urban versus rural, that would be interesting.
I might be jumping ahead a meeting or two, but I imagine that you're starting to think through the 2027 survey, and I'm curious if you're planning to set anything in reaction to some of the changes that are anticipated in federal policy.
The team doesn't fall off their chairs yet, thinking about 2020. We're sort of right near the finish line. No, I think it's a very, very fair question, and we are sort of constantly thinking, wrapping one survey up and the next day starting to think about the following. And it's my hope that after in releasing this 2025, it will spur a number of sort of different questions, analysis that we can consider for 2027. But the large elephant in the room is certainly the federal changes. And I do expect to see shifts in coverage. And I think we can think about and would love to get your input on this as well, as how we can, what's a nuanced way that we can capture some of those dynamics beyond just, okay, this is what our uninsured rate is.
Anybody else for the director's report? Okay. And Eric. So as you're going up there, I cannot resist, but I will point out that on a national basis, 35% of the people with medical debt have. So if we covered people, we might cut it down a lot. That segue.
Reasonable prices, more dentists would take it.
Yeah.
Let's do it.
Hi, everyone. So let me start from a quick intro, as this is my very first time, presenting here.
Those of us who would love you to speak up a little louder, if you wouldn't mind.
Okay.
Especially for those that are listening.
Oh, sure.
And welcome. We're nice, I promise.
Thank you. So my name is Eric Yan, and I'm an associate manager on the health informatics and the reporting team at CHIA. So today I am here to provide an overview of a new project that CHIA has undertaken to support more detailed analyses and reporting about oral health services in Massachusetts. So we know that oral health is essential to pretty much everyone. For example, access to preventive care not only improves oral health, but also reduces the risk of additional health problems for patients with chronic conditions, such as like pregnancy complications, heart disease. However, with oral health care typically covered outside of traditional medical insurance, Massachusetts residents face obstacles such as lack of coverage, limited services, high costs, and trouble finding their in-network providers. CHIA's survey of residents found that oral care was the second most common reason that families struggled with their medical costs. Patients, were lower among Hispanic community, lower income residents, and those reporting poor health. In 2022, the legislature formed a commission on oral health with CHIA as a member to assess needs and recommend ways to improve access. A clear takeaway is a public report regarding oral health is essential to support policymaking efforts. So talking about our work so far, to address this issue and establish measures about the oral health care system in Massachusetts, CHIA has been analyzing oral care oral care claims per month, aiming for public reporting in 2026. So far, we have received oral health claims and member enrollments from over 20 payers in our APCD. So some payers offers oral health coverage only, while others offering both medical and oral health coverage. So since this project is very new to us, we first need to confirm, what payers submitted to us supports our planned analyses. So last month, we shared the payer profiles in something we called payer verification workbooks. And we are currently reviewing any findings with them. So later this month or next month, we will finalize which payers to include. And we are planning to have another meeting with Faye regarding the analytic measures and potential topics that we will include in our future publication. I think that's all I have. Thank you, everyone.
And I think, they had offered to convene a small group of experts in the space because this is a new frontier for us. And so we wanted to both sort of open up to get any initial thoughts from the council as to what we should be looking at, but we'll certainly be taking Faye up on the offer to convene some dental experts. So if you know of anyone, that would be good. Please let us know. But we're all ears and want to make sure that we're producing analysis that is most useful in the space, because we know that it is so intrinsic in so many of the other healthcare problems and challenges that we see. So we're excited, but are very much welcoming any feedback or shared expertise.
What are the questions that we hope to be able to answer?
Is what we got the group asking. That's exactly what the group is asking. Because it's very different. It's not medical. It's dental.
So dentists tell me that if patient has insurance, they try to raise their price and have the insurance pay for some of the higher price when they can. It would be useful to know, I think, the differences in actual prices paid by different payers. If the All Claims database permits that. And then whether there's any follow-up work that might suggest that patients with better coverage or whose insurer plus out-of-pocket payment is greater get preferential access. So that would be hard to measure and hard. They might not be willing or able to report that. And the APCD probably doesn't permit it.
It's great. Throw out ideas. That's what Lauren is looking for. We're not going to have a discussion on pluses, minuses, candidates, but ideas like that would be great. And,
question if these claims data include these newer kind of membership models that some dentists are now offering, because there's so many people that don't have dental insurance. I think it's still a relatively small segment of the population, but I've seen more and more dentists
I
offer
just described to everyone what you're talking about.
I don't know them well, so please chime in,
You're right.
but it's essentially like a monthly membership model where
Exactly what it is. You don't have insurance, but you can pay monthly as a prepayment essentially. And they'll give you a discount. But that has some issues. But a great question. Other ideas? You've looked at this.
I mean, if it's not insurance, it's probably not gonna be in the claims. It's like the primary care concierge
Yeah.
stuff. It's very tricky. I guess I also have a question. Does the claims data indicate whether the patient is receiving that service out of network? If the dentist is out of network or in network?
I think theoretically should include both out of network and in network providers, as long as it comes from a payer.
Yeah, I guess I was interested in knowing if we can flag that and understanding for different health plans, how much proportion of their membership is actually getting care out of network or in network, and that may tell us something about the adequacy of those networks and how much care, and the differential cost of those care if patients are ultimately going to dentists that are out of network. I think that the out-of-pocket patient costs are just so important in this space. That would be an area that I would want to try to focus on first. But then thinking about what are the variations in provider pricing, secondarily and network adequacy. But I'd be very fascinated to understand kind of the range of what patients are paying out of pocket for different types of services.
I think we do have the member cost sharing.
Yeah,
field
I would
available,
assume, yeah.
so,
I don't know the dental insurance landscape very well, and I actually do have a colleague I'd love to recommend to you guys, but does dental insurance run into the same issues with self-insurance and a lack of obligation to report as medical insurance does?
Yeah.
Okay,
It still runs into the ERISA
yeah,
preemption.
yeah.
issues.
okay.
I think per the Affordable Care Act, for children, dental is part of the essential health benefits, right? So if that is the case for kids, we should have pretty reliable insurance information, or that didn't work out the way.
Yeah, the way that it should. I had it this morning and I meant to be good, but it didn't work out the way it should. It's a marvelous children's book.
I think the other challenge is that a lot of kids who have parents on marketplace coverage are in mixed status families where the
Yeah.
kids are on Medicaid or CHIP, but the parents are on marketplace
But I
coverage.
think what you're asking is the complexity of how it works and who's on and who isn't.
One bottom line measure might be, if it's possible to learn how many people are covered by each of the different plans, what is total spending per member per month? Not premium, but actual spending on care per member per month. And also the breakdown of frequency of services. How many people in a given plan have teeth excavated and filled? How many have crowns? How many have extractions? How many have implants? Number of rates per 1,000 members, and also spending per 1,000 members on each of those services.
Yes, I would say at least some of these measures we are already working on is like the PMPM calculation and also the coverage rate and also the service type analysis. So they are all on our list. So you will find them in our publication.
Yeah, for actually, for those of you that are interested, the Division of Insurance in 22 did a very good report on the number of people in Massachusetts who have claims. And the percentage that died as an individual, the percentage that died as a group. And lots of people aren't covered. Well, it's part of the problem. They don't have claims.
Yeah, Alan's questions raised to me, I guess another question was like, is there an appropriate health risk adjuster for understanding different rates of utilization among different patient populations? And I don't know, maybe it's the same health status risk adjuster that we would otherwise use, because if we're looking at different, rates of different types of services and comparing different, in this case in terms of the providers, you'd want to understand, are there underlying risk factors that might lead to different rates of different types of treatments? But I don't even know. I don't know. Now we're really getting out of our depth.
Yes, a great point, because I think what we should do is really set the context of how dental insurance is really insurance, because everybody tried not to call it insurance at the beginning, but everybody called it insurance, so everybody ended up calling it insurance. But if you have $1,000 max, which almost everybody does, you eat your $1,000 in the preventive care. So it's hard to measure, and then each plan is different. It's like So I think we should set up a context of why this is different than medical in those senses. And some of the metrics may be more what Alan was going to on utilization, as opposed to cost per. But I think it's going to be very helpful to get a group of people who really look at dental analysis and don't think medical, think dental, because all of us go into medical. Anybody have any other ideas? Then throw them out, and not throw them out, throw them in. And feel free, because we're starting next week to build the team to take a look at this. It's not a lifetime commitment. It's really just to help set the context. So don't work in your own houses. Keep thinking. Thank you. But moving right along.
Take care.
Thank you, everyone.
Thank you.
Thank you. We look forward to more. Molly.
Hello, I'm back. Okay, so I'm going to shift to talking about our new PBM data collection, we were given this authority under Chapter 342 of the Acts of 2024, which amended our authority to collect data from pharmacy benefit managers. So I'm here to attempt to provide a more in-depth description of the role of PBMs in the prescription drug supply chain, and then we'll also talk about our upcoming data collection and next steps with that. So this chart attempts to simplify a very complex system, as you'll see by all the boxes and the arrows. So looking at this chart, the major players in the system are represented by the boxes, with the blue arrows showing the flow of the drug product, and then the dotted green lines representing the flow of money, which reflects various payment methods. So starting with the flow of prescription medicines, those begin at the drug manufacturer, which are then purchased by drug wholesalers, who purchase large quantities of pharmaceuticals at their list price or wholesale acquisition costs, which we'll also get into later, and then are distributed to pharmacies and then on to the patient. So the flow of funds in the prescription drug supply chain is more complex, with the PBM acting as a middleman. So the role of the PBM is to administer prescription drug benefits on behalf of health insurers and plan sponsors and act as intermediaries in the prescription drug supply chain, including managing services like creating drug formularies and utilization review, processing claims, contracting with pharmacies, and negotiating rebates with drug manufacturers. You'll also see that in between drug manufacturers and PBMs, there's this entity that we're collectively calling rebate aggregators, or are also known as group purchasing organizations, or GPOs. These entities negotiate rebates with drug manufacturers on behalf of PBMs and collect fees for their services from PBMs. You'll see that the health plan or health plan sponsor pays administrative service fees and other fees to PBMs for their services. And then I specifically want to draw attention to the green dotted line of post-sale adjustments flowing from the pharmacy to PBM. So post-sale adjustments represent the PBM business practice of clawbacks, aka recoupment of funds from pharmacies after a claim has been processed and dispensed. So this happens when a patient pays a higher copay than the price set by the PBM, with the difference then being clawed back by the pharmacy to the PBM. So this practice increases patients' out-of-pocket costs and lowers pharmacy profits. Another box on the graph is the 340B covered entity and program, which only further complicates the prescription drug supply chain. So our CHIA's new PBM data collection aims. Oh, goodness. That's a complicated question.
I did see a couple people blank.
Yes, okay, so
What will it be?
oh,
What's
goodness.
it currently? How's that?
What is it currently? Okay, great question.
2 sentences.
I'll try my best. So it's a federal drug pricing program in which the covered entity, so a hospital, can purchase drugs at a discounted rate to support providing services to low-income and uninsured patients. And then these covered entities contract with pharmacies to dispense these medications. Lauren, do you want to provide more color?
I would just say
That was
that.
good. You should
Oh,
have
no,
said
no, sorry, that's great. And so I think informally, we'll say a 340B entity, that could either mean the hospital or the pharmacy, CVS, for example, that they contract with.
Yeah.
And sort of we umbrella call that group the 340B entities.
I think what helped my understanding of it was that 340B is attached to a patient and the patient via the patient's connection to a hospital system.
Yes, that is the technical way to think about it.
Yeah.
That's correct. I think just for the purpose of the regs and the way that we're talking about it, we sort of use that potentially to refer to a hospital or a pharmacy, just as a context.
Or community health centers.
Yes.
But the notion that this is linked to low-income people or people who have trouble affording meds gets very cloudy.
Yeah.
Because the hospital can charge commercially insured patients full freight. But we're getting now into the tricky distinction, and I'm not sure if it's relevant, but it's worth mentioning, between retail prescription drugs dispensed to individuals as outpatients versus meds for hospital inpatients and nursing home residents, which are not, I think, the scope of our work, even though that's another 25 to 33% addition, add-on to total pharmacy spending, prescription drug spending.
This is actually helpful to understanding then what the PBM is, which is why I think the chart was really, thank you. I like the visual. So it's irrelevant. I mean, so PBMs only deal with patients outside of health centers and health community. No, they have pharmacies and hospitals.
PBMs.
Yeah, it doesn't.
PBMs work on behalf of health plan sponsors. There's
So if I get my drug from a community health center, I get my drug from a hospital, it's PBM.
the PBM.
Patient.
I think PBM is specific to the Part D, but as it's the Medicare
It's-
concept, that's the Part B component, which is the hospital dispensed drugs for, hospitalization services.
But the larger med is not even counted in national health expenditures as pharmacy spending. It's meds for hospital inpatients, just covered under Part A.
Yeah,
Under
sorry.
DRG
yeah,
payment.
Yes,
Yeah.
right.
And we're not looking at that.
I believe this is a Part
Help
B,
us focus on
D
what the law
specific.
requires us to look at.
Part D type.
That's
Yes.
great.
Yeah, so we're gonna get into this a little bit on the next slides, but we're gonna be looking at pharmacy benefit managers and we're going to be collecting utilization information. So what type, number of, drugs in the, think retail setting, so your CVS's, your Walgreens, et cetera. And then we're also gonna follow the flow of rebates from the drug manufacturer through the PBMs, and then how much of that is passed on through. We're also going to look at post-sale adjustments. So what's happening with the spread pricing, the clawbacks, they're kind of PBM business practices. And then we're also going to be looking at reimbursement methods. So how much is the PBM covering on behalf of the plan sponsor, and then how much is the patient paying? So basically all of them, in short,
Complex task.
very, yes.
Okay.
Will you be able to measure something like the share of meds paid by patient plus insurer for outpatient retail prescription drugs that goes to the pharmacy, the PBM, the wholesaler, manufacturer, or other parties?
The share of the payment?
So all this, we,
No, like if $100 is paid for a drug, we're not understanding the profit of where that $100 is going. We're the flow that we're going to be understanding is the flow of rebates. We won't be able to break down like the, a patient paid $100 for a drug, who's capturing that $100.
Yeah.
We just know that that's going into the system. Like we're not going to be able to discern like profits off of that.
or how much money sticks in different
Yeah.
pockets.
Yeah, the flow that we'll be following is like the rebate. So when the PBM negotiates a rebate, how much of that are they passing through to the health plan sponsor, and then, or how much are they passing through to the patient? That's the flow part that we'll be able to understand. From the reimbursement perspective, we'll be able to understand the reimbursement practices, not so much like who's pocketing the reimbursement.
You say reimbursement, payment,
Payment, yeah.
what about discounts?
I'm not sure how those are captured in here. I think we're still working on building out the template. So I think we might be including some broader things to capture a lot of the like on the edges things, but we're still working on trying to understand all the different payments.
Do you mean discounts at point of sale? Point of sale discounts, with coupons?
Not coupons, but everybody pays a different price.
Right.
Pharmacies often are paid different prices by a PBM. Different PBMs often negotiate different discounts on behalf of different corporate clients.
That's not the rebate?
Not the rebate. The discount is taken. The rebate is on the money actually paid. Some of it is rebated, but some of the money, some of the saving is the rebate to the patient or to the corporate.
Very rarely to the patient.
The discount affects the patient and affects the employer the same way as a rebate does, net, because it means they end up spending less for the same drug. But the mechanism is entirely different. And some people think that rebates should be outlawed and that only discounts should be allowed so that the flow of money is much clearer. And your job would be much easier.
I'm unsure about the discounts. I said I'm currently unsure about the discounts. We're still building out our collection and working with experts, luckily, in this field. Yeah. Any other questions on this slide? Yeah.
This is super helpful, thank you. Just curious, in the analyses that you're planning, given that there is quite a bit of consolidation and also vertical integration, is that something that you'll be able to maybe do a sub-analysis on to see if there's a differential impact when that happens?
Yeah. I mean, I think we're in year one. Year one will be kind of gathering. We're trying to figure out what we don't know at this point. I think there is some questions where we're going to try to understand like the different entities that the PBM also owns or has stake in. I think that might be part of the DOI's venture as well. So I think it is eventually, to understand the whole picture, you have to understand all the integration, both vertically and horizontally.
If I can chime in too on the DOI side, we do have our bulletin that's out for the initial licensing for PBMs, and we're issuing a proposed regulation relating to that. And so part of that is to gain a better understanding of who are the players in this space and understanding kind of the structures of those entities. So it is happening on our side in collaboration with CHIA and the work that they're doing.
Okay, so speaking of the DOI will be providing us with a list of licensed PBMs once they finish their process in January, and then this will identify our data submitter pool. So the new law that gave us this authority required us to consult with affected PBMs and pharmaceutical manufacturers in the development of this new data stream. So we held a listening session on data collection materials, including the templates and the specification manuals with stakeholders, and received feedback from that. We did that in early November. We also filed 957 CMR 12, the regulation for this new data collection, and we held a public hearing on November 20th. So as you can imagine, we received feedback from many organizations with different viewpoints on how to collect this information, and we're currently working through those comments. For future work, we're hoping to finalize our data collection materials in January of 2026, with then an anticipated data collection in spring and our first public report in late summer. Any questions on this slide? Next slide.
This is our chance to start with questions on PBM. This is new to all of us.
So under number 3 out of the 6 analytic questions that were circulated, difference between list prices of drugs and what pharmacies are paid. Will you be able to measure the prices that different pharmacies are paid for the same drug?
We're not collecting at the pharmacy level this iteration.
Okay. But what pharmacies are paid? How to learn that? Will you learn that like an annual aggregated figure paid by the PBM to all pharmacies?
Yeah, it'll be aggregated, and it won't be individual pharmacies, but we'll be able to determine like pharmacies as a whole. Yes.
How about the distinction between Optum and its mail order pharmacies, CVS and its mail order pharmacies? No?
No, we're not collecting
Okay.
pharmacy level data.
Okay. Under number 4, what are PBM profits?
Are you going to the questions that were discussion questions that were passed out earlier? Is
I
that?
don't have those.
Oh,
Yeah. Let's stop and make sure everybody knows what we're talking about.
It's in the emails.
Was it
Yeah.
the email that came out yesterday?
I'm wondering if, Alex, I can send it to you and then we can.
Let's see what the-
Yeah.
or-
Want to just state the question aloud? Would you rather?
Yeah, you can keep going with this.
No, if you state it out loud, so Kumali.
Oh, no,
Understand where we're
keep
coming
going.
from.
ambush.
And her team will, I was gonna say, and her team will help her out.
Yeah, so PBM profits, what we're gonna be collecting is those administrative service fees that health plans are paying PBMs for their services. So, and then also understanding the spread pricing and the clawbacks, which are PBM business practices for profit. So we'll start getting at it that way in the first iteration.
On that point, PBMs have occasionally been accused of accepting payments from manufacturers, which they actually acknowledge, for data. But some people have said those are actually called bribes. And there's been extensive civil litigation, which some PBMs have settled for millions and millions of dollars, saying that the PBMs had violated their fiduciary duty to their corporate clients who were paying them for the meds by accepting payments from a drug maker to prescribe to place its higher priced med higher on the formulary. Will you be able to capture any of
No.
those payments from drug makers to PBMs?
No, we'll be looking at rebates for that flow from drugs to PBMs. We won't be able to get at any of those.
Could it be a separate question saying, have you accepted a bribe? No.
Oh.
Have you accepted other payments from drug makers?
I don't know if our authority extends to that,
I
but
think that one of the things that we're learning in the space is when the original legislative proposal came around, rebates was the common practice. And the industry has sort of evolved to call these things administrative fees and put them under different buckets. And so I think part of this first iteration is to really get a definitional understanding, knowing that they're going to continue to evolve, rebate. But the goal is to be as broad as possible in how we're defining or talking about rebates and fees that we're trying to capture data on, knowing that they're evolving, PBMs are evolving their definitions. And so we're trying to be as flexible and broad as possible within our statute.
Which concerns only rebates.
Well, I think that's my point, is that now a lot of PBMs, they don't even talk about them as rebates, they talk about them as administrative fees. And so we're sort of saying all of these different practices are getting put into one bucket, whether you call them rebates or administrative fees. Those are the amounts that we're collecting.
I think in our template that we're working on building with our consultants, we are trying to capture some of those additional like other fields, like, but it is hard to define all these things, like Lauren was saying, they're kind of popping up in response to new data collections as well. So I think year one is trying to understand what we're collecting and what it represents, even as you saw, it was a very complicated system.
In fairness, we do all recognize this is brand new and first pass. And we're
Yes,
gonna get better and better as we go along,
ideally.
but it's good to have this discussion right off.
I'm sure we can find someone who worked in a PBM, just give us a workshop so that all these sort of nuances are explained so that we can sort of understand the why it was the history and then what it is. I feel like, a little bit of just understanding from the inside will give us a lot more guidance to piece things together.
If you have any recommendations, we would welcome that conversation. We did contract with a technical expert who
Okay.
had worked with other states on similar PBM collection, so we are working with some experts, but we would welcome any.
That's why I'm not an expert at all, but I could feel like.
I have one in mind too.
Okay, we can
I don't know
think
that
about
anyone
that,
currently
yes.
working for PBM is gonna wanna
Yeah.
come and
You
come
will be
forward.
ex-
But if you have any ideas of those.
Can I raise in response to the first question that is listed on that, what's on the slide? I just want to flag that, so obviously this is a kind of multi-agency effort, and we're working on the licensure of these entities. But we will be collecting the information that is listed in question 1 over at DOI. And so I just wanted to raise that as like, to avoid duplicative work and potentially differing data, since like everyone is saying, this is kind of the initial work that we're doing to kind of understand the landscape and the players in that. So I just wanted to flag that up front for that first question.
Thank you. That's helpful.
And then I'm assuming the second question, top drugs by volume, we mean dollar volume versus the scripts, right?
We're gonna be collecting both utilization and reimbursement metrics, so we could identify it either way.
Okay, because in pharmaceuticals, we know there's a sharp inverse relationship between price and volume. There's the penny generic and the brand and the specialty. So they're very, very different animals. I would start with specialty pharmacy. In fact, that's probably the most telling.
I do want to jump back to the last slide. So I think just quickly, the slide talks about what we were just talking about. We're going to be collecting both utilization and reimbursement metrics. We're also going to be collecting information from PBMs on their formularies and which drugs are subject to like creation of drug lists, drug placement, and utilization management programs. As I mentioned, we're also going to be digging into clawbacks and spread pricing. So spread pricing, we discussed clawbacks, but spread pricing is when a PBM charges a health plan a higher price for a drug than what it reimburses the pharmacy for, and again, keeping that difference as profit. So as you saw on the list, we're going to provide it's going to provide some baseline metrics on top drugs by volumes, what conditions they treat. And then I guess I'll open it up to like the discussion part now. So as we develop the analytic plan for this initial and future reports, are there specific measures or analytic outputs that the council recommends CHIA consider including? This last one's a big one. What other questions does the council have about the prescription drug system?
I think many of us are simply a little confused at the moment, so we're, thinking it through, and it's really helpful, and keep educating us each time you talk about it.
I'll try.
And it's shifting sands, it sounds like. So the SPAP client rebates will help anything else. But anybody have any thoughts about what we should give as guidance?
Will, under these 7 headings together, will you be able to measure something like the revenue PBM earns on commercially insured Massachusetts patients and its expenses, and the difference, their profit?
No. We'll be able to know the profit it makes off of rebates and administrative service fees and other similar fees paid for, but we have no insight into expenses.
If you don't have insight into expenses, I don't understand how you can measure profit.
We're measuring
do you
the
mean
profit from those streams.
How can you measure profit if it's all, forgive me, profit for me is revenue minus expense.
Then I think we mean maybe revenue in this instance over profit. We have no insight into PBM expenses.
Or how
Nor
much
does this
how
give
much
us-
they pay drug makers.
I mean, we'll have the wholesale acquisition costs, we'll have the flow, but we're not going to be able to assess the profit of PBMs on any level.
Okay, how much they act, oh, so we won't know how much they pay to Merck or J&J.
We're gonna get the wholesale acquisition costs, but
Yeah,
I'm not sure about like,
So we'll be able to see something like along the lines of, like looking at drug categories, we're not gonna see a PBM's bottom line, like operating bottom line. What this will give insight into is, let's just take diabetes drugs. What are PBMs getting a windfall off of diabetes, insulin, diabetes drugs, or in terms of their rebate or administrative fee practices because of what the wholesale acquisition price is versus what they are paying out?
Yeah, well, their wholesale acquisition price isn't what they pay. So I don't know. How you get that difference. All the prices and wholesale acquisition cost, wholesale price, average wholesale price, they tend not to be the prices that are actually paid, owing to discounts and other factors. So I'm not sure what ground we can actually stand on here, as opposed to sink in.
I think this analysis in statute was very much targeted at PBMs, looking at practice of PBMs. You're right, we're not going to get the detailed insights into the practice of the manufacturers. That was elsewhere in the statute and outside of, not in CHIA's purview. So I think what we're trying to do now is collect as much information, even if it's not doesn't give us a perfect revenue minus expense. I think based on what's in the statute, we are going as sort of bold as possible in terms of what we're collecting, and then from there we will be able to discern.
Please be sure I'm not criticizing in any way, and perfection is rarely the objective. I just don't understand what revenue we'll be obtaining, what costs we can subtract from that, because I keep hearing the word profit. And it doesn't sound like we're going to be able to learn that.
So what I'm really hearing is that we need to be very careful about the words we use, because everybody sees profit and thinks that's the profit the PBM is making, and it's not necessarily that because of what you've just described.
I definitely don't want to speak for CARE and DOI, but I'm just looking at the licensure requirements through DOI. And, there's going to be some information here, Alan, that gets to organizational charts, that gets to financial statements.
Yes.
So there may be some information that paired with what comes through DOI with CHIA will help answer some of these questions.
Because they're getting the revenue.
Yes, and it's all, it's all linked into what our authority is under the statute too. So we're each kind of doing our collection of information at this time, and it's the initial kind of way of doing it. And then obviously we'll modify and adapt.
So sorry,
Go ahead,
I actually think that even though it's very easy to get into a lot of weeds and end up becoming very confusing, I do think that we can learn a lot from the rebates. Because if you think about the origin of these rebates, right? Because with the basic contract, this is me on the insurance side, so it's not all visibility. So my understanding is that the basic contract between the PBM and the insurance, which is the purchaser from the PBM, is fairly simple. It's typically AWP minus 20. So there is no contracts for these rebates. So these are really, sort of random things that will happen. So you'll wait for rebates, and then the most that we can say is that if there is a manufacturer rebate, you need to pass on to us, or you need to pass on to us by no less than a certain percentage. So these rebates, if you think about it, because there's a big difference between pharmaceuticals and hospital. Right? Hospital, everything is indexed back to CMS price setting, so it's MedPAC and everything. But so it's basically government set pricing as a benchmark. But pharmaceuticals, there is no, at least in this country, AWP, ASP. At the end of the day, it's manufacturers set pricing. So therefore, they can set whatever they want. And then, especially with 340B and everything, they really make sure they have a lot of margin. So I bet if you start with $100 and then look at where dollars, and most of it is with the manufacturers. So they have a lot of discretion to pay these rebates, especially the PBM industry is so concentrated. So just 3 guys, right? So they have to do a lot of things to manage the relationship and then give them the sweeteners. And by the way, the contracts between PBMs and insurers are very long. They're like 5-10 year relationships. So it's not a lot of switching. So it's just managing these relationships day to day to influence the formulary, for example, is huge. So there's a lot of incentive to make the PBMs happy. So that then so because there is no sort of at least transparent contracts for these rebates often become windfalls. And then because they don't really share it, with the public on how much money they're getting and then how they're passing it on. So they end up sort of packaging a lot of these profits. So I would just say, without understanding a huge amount of details, just understanding the rebates actually is very useful because it's so unique. If you think about the relationship between pharmaceuticals and a very, very concentrated PBM market and the insurers, which is on a downstream, and it is a completely opaque relationship. There is no contractual parameters around these rebates. Does that make sense?
It did. Scary. It did. I think it'd be helpful for all of us also to understand what the DOI is doing, because it's clear to us, at least as I'm listening, that there is a lot of overlap. And that would be helpful as we think about the kind of questions we need to think about.
I think Adrienne.
So recognizing that this is the first year and you're not necessarily thinking longitudinally yet, I do think it would be interesting if, as you aggregate data over time, we could learn something about the role that PBMs play in the drug pricing strategies that we tend to attribute to manufacturers, evergreening, product hopping. Like, are there sort of versions of that PBMs engage in, sort of independent of whatever the manufacturer is doing? I am more out of my depth in drug pricing than I am in dental insurance, so I don't know much more than those 2 phrases, evergreening and drug and product hopping. But it is something that I think is very interesting. And if you have flows of revenue that help us understand PBM's roles in supporting or suppressing those types of practices, I think that would be really useful.
I have not heard those words, so.
Other thoughts from the council?
If it would be helpful for the next meeting, I can come. I have a colleague that's been working on this regulation, and it's proposed and will have gone through the regulatory process probably by the time we meet next. So I could come or invite that individual to come and brief you on what we're doing over at DOI in this space.
That would be very helpful because it's a broad context, so that we don't sit there and talk about all the things here that we think we should be doing to discover that you are.
Yep. Sure, of course.
Just circling back to our earlier conversations about the cost trends hearings and the sense of crisis, I think recognizing that no country with real healthcare has PBMs. A few Canadian provinces do. That's because they're really weird. But no other country does. They don't need them. And their existence in the United States makes the job of making meds affordable for everyone even more complicated than it is elsewhere in countries that have done much better. More meds for more people at less cost. PBMs are a phony remedy and a distraction, and allegedly prone to widespread corruption.
Thank you for your opinion. You still have to do all the work. Any other thoughts? Thank you. We blindsided you a little bit,
No, you're so
but
good.
hang in there. Really important
I'm
discussion.
sure I'll be back.
And recognize that we're all
Thank you.
with, yeah, in terms of understanding. Great, we do have other prioritizers. And is Erin going to talk about primary care?
My ordering update on primary care and behavioral health. Okay, so kicking off the priority areas section of our agenda, I will try to keep this brief. So the first thing, so to start off, I wanted to provide a quick update on CHIA's recent activities related to the ongoing primary care task force. So the first deliverable from the task force was issued in September. Broadly, the recommendation was to continue CHIA's role and methodology in defining and measuring spending on primary care services. That deliverable included some specific policy recommendations and considerations that CHIA is currently working on in terms of assessing feasibility and options for how we might be able to adjust or incorporate. That is a very brief overview in terms of what we have been doing. David, I'm going to put you on the spot. I don't know if there's anything additional you want to say about the activities of the task force so far.
Just a note of appreciation for the partnership with CHIA. We are also working on a deliverable number 3, which is around establishing a primary care spending target. The current recommendation that we're discussing would be to double the share of primary care spending as a share of total healthcare expenditures in 5 years. And the current draft recommendation would suggest that HPC and CHIA be the primary oversight entities for such a recommendation. So CHIA continues to play a really important role in the work of this task force. And so thank you.
Great, thank you.
When you say you are currently evaluating and assessing, are these things that are in the hopper now for CHIA to be thinking about, to give to the, as a recommendation to give to the health policy?
So some of the recommendations, there were a couple of them, I have not memorized all of them yet, I will be upfront. So like one of the recommendations was CHIA should consider how best to capture other non-clinician providers. So our side of that is, this is the recommendation in the deliverable from the primary care task force. What is currently reflected in our methodology? What types of providers are there additional, and how would we, is it something feasible that we could address in our methodology or in our reporting? Whether it's our expenditure reporting, the primary care dashboard that we're going to touch on. So going through that exercise with each of the recommendations of, do we have anything that can currently address it? Are there options as to how we could incorporate, and is it feasible? Does data exist? What would we have to do?
So some of the things that we're working on are not, the deliverables are not predicated on this work, but they will only sort of advance and enhance work, like figuring out a solid source for original Medicare data in this space. It was identified by the task force. We know that if we holistically want to be able to capture primary care spending across all different care programs, we need original Medicare. That is something that we're the ongoing work that we're trying to tease out, but it's not going to stop the policy recommendation for deliverables from advancing.
Do the Medicare financial intermediaries for the state have those data?
Medicare Advantage plans?
For traditional Medicare?
That I don't know. I assume that if they have them and we knew about it, we would have better data in the face, but I don't know.
Or everybody else may know, but just in case there's somebody else who doesn't, what exactly is original Medicare? Fee for service. Fee for service. Yeah. So we don't get fee for service Medicare.
Not for primary care and behavioral health spending currently.
Actually,
We have data we have spending data for Medicare Advantage, but we don't have. Correct.
good old fashioned card.
Correct.
Not-
Yes. So that is a gap, that it's a set of data that we currently don't have. Recommendation to include, and so we are currently, is there data that's out there? How can we capture some of this and make inroads to identifying and including that spending in our reporting?
Thank you.
Okay, moving on to the next slide. So looking at the primary care dashboard specifically, We are coming up on the next iteration. So as a refresher, this has been a product that CHIA has put out, I think we're on the third iteration, and anything, this also relates to the work of the task force where CHIA's primary care dashboard will serve as the publication where a lot of data and recommendations from the task force live. So looking to upcoming publications, the primary care dashboard is targeting a spring 2026 publication. A few updates that we're making this year. So we're including some new measures on providers that are accepting new patients, some additional measures on behavioral health, prenatal and postpartum care, and we also are going to include data from CHIA's workforce survey for the primary care sector. Here we have a couple longer term topics that are on our list. So things that we've heard from stakeholders that are important to measure, and we are looking for how can we capture them. So these things include wait times, Medicaid acceptance rates, and more administrative topics like provider burnout, concierge and direct care practices. So, you know, we've heard from this group, we've heard from the task force and others that these measures are important to track, but the administrative data sources don't necessarily exist to be able to capture these, or they're not straightforward. So one question for this group is, do you have recommendations on data sources to capture any of these topics or any data to make inroads on this?
It's resource intensive, but secret shopper studies are the ways that you typically see people get at wait times and what payers providers are accepting.
Some of the workforce doing address provider burnout.
It's because it's more demand side, it is the HR departments and administrators that are filling out. So we capture some of the reasons, for example, like why there's high turnover rate. There are some qualitative questions as to reasons what might be driving vacancies or high turnover rates, but we don't have any, at least in this iteration, we have not sent the survey out to primary care clinicians to ask those sort of questions.
Very basic question. What data will be reported in the dashboard on number of primary care physicians, MD, DO, nurse practitioners working in primary care, PAs working in primary care? And if we have gross numbers, we say that they're devoting the usual more than 20 hours a week to patient care. Do we have the capacity to begin to convert those numbers into full-time equivalents, which we could compare with needed primary care capacity?
We'll have to take that back.
We had talked about that a year or so ago.
You're getting at certain permutations of that, but so I can answer sort of your question precisely and compare it to what exactly on this round of workforce. Take it back and then.
Thank you.
Aaron, I just a suggestion on I know the use of urgent care centers. This is something that, you know, we've done some work on in the past, and it's been pretty labor intensive because some of these urgent care centers are licensed in different ways. Some of them are clinics, some of them are physician offices. The legislation at the beginning of the year directs DPH to set up a new licensing structure for urgent care centers so that they are all going to be kind of have a repository about who they are and some designation and identification of them. So it may be worth at some point touching base with DPH about where they're at with that process. And then once that has happened, then you'll have a known universe of organizations, and we could probably then be able to pull some information straight from the APCD if we can start to link to that.
Yeah, that's a great suggestion. We've talked to DPH, I think, on probably every other type of license that they've issued in this space. So happy to connect with them again on this one as well.
Yeah, on the concierge medicine, direct primary care, this is something of interest to us too, so we can take this offline and think about it. I think at this, unfortunately, it's probably gonna be some Googling and survey work.
Yeah,
There's no kind of set repository for understanding this information.
Yeah.
That's kind of how we did it with urgent care centers too, was like,
My time on the internet has yielded that there isn't a great, there's no clean list of concierge or direct care providers. But yeah, so we know that it's of interest to a lot of entities. You guys are working on it. There's a lot of interest in a lot of people that are also trying to tackle this. So, but acknowledging that it's on our list too, and definitely would like to collaborate.
Yep. As you're considering finance measures, it might also be interesting to capture kind of organizational or corporate structure, especially as we see many like independent practices, nonprofit practices convert to kind of corporate practices. And I've heard anecdotally just the impact that has on wait times, access to providers.
Yes, practice ownership.
Any other suggestions? Great.
Okay, so pivoting to the behavioral health dashboard, so also slated for a summer publication. So work to date so far, where the team has been meeting with various stakeholders to get input and get feedback and solicit input on what measures are most meaningful and useful. And the behavioral health dashboard is one iteration behind the primary care dashboard. So that's what we've been doing so far. A couple new things that we intend to add in this year will be some measures specific to behavioral health for adolescents around utilization and some spending. And similarly, we're including here a few of the longer term kind of wish list topics that we are investigating for future iterations. So some of the things that we're thinking about beyond this cycle.
I was thinking the same.
She can touch base if she has anything.
Not the last time that
This is
we
not-
will close this question.
You will see me here in this very seat in first. I am certain of it.
Thank you.
All right, thank you.
On the heading of primary care, I wonder if we could get a rundown from Mass General Rhythm. In primary care. They promise.
You're looking for a breakdown?
I'd like to know how much they've spent. Reading primaries.
CHIA does not cover.
I know we don't.
Not our job. Okay.
No,
I didn't say
I
that.
didn't say, she just,
Oh,
we don't have a
it's-
breakout.
That's totally legitimate. There must be something that's not our job.
But I think just moving away from MGB specifically, I think one of the areas of discussion on the task force has been, how do we measure primary care spending and investment on the provider side? It's clearer and more straightforward to collect that information on the payer side, but understanding and acknowledging that so many of these, the large majority of primary care practices in the Commonwealth are part of big systems. One of the things we are trying to figure out and better examine is the way in which those provider systems are investing money in primary care practices.
And that goes, that may dovetail with some wonderful data that she has been presenting, showing hospital, for hospital affiliated physician groups, including primary care, sometimes with primary care broken out separately. operating margins, almost all of which are grossly negative, which means that the hospital is subsidizing the physicians in legal ways. And so they're certainly underwriting primary care. In New Hampshire, for example, hospitals cheerfully admit they have now been responsible for primary care practices, for keeping them open in much of the state. So that, I think that's a very promising to take.
Your turn, you're up.
Great. So I have some updates for you all on just a couple of items, and I'm going to start with health equity. I've shared with this group before CHIA's 5-point health equity strategy, which is meant to guide and advance our reporting. And so the first update that I have for you all regarding our point to enhance our current data assets, CHIA is making advances to collect sociodemographic information from health insurers who submit to the ABCD with a new member simplified file to sort of supplement some of the eligibility information that we have. This file is going to have the enhancement, I suppose, is information on race, ethnicity, language, disability, sexual orientation, and gender identity data elements as much as payers have that information. And right now where CHIA is at is sort of finalizing some of its data infrastructure to be able to intake this information and starting their testing process. And it's our goal to begin this data collection in earnest in February 2026. As a follow-up to one of our other points in our 5-point plan to improve the visibility and utility of CHIA's reporting, earlier this year, we did release our inaugural health equity dashboard, which is meant to monitor health disparities in Massachusetts. The dashboard currently showcases measures of these disparities that are currently monitored at CHIA with a focus on findings that are specifically related to race, ethnicity, and geography or region. And so we put that work out in May, and it is our intention in the upcoming year to update this dashboard with some of the latest reporting that CHIA has published since the dashboard's publication. And as part of this update, in addition to sort of reviewing new publications that have been put out into the world since the publication of that, we're also going to look at other metrics that might be included beyond ethnicity and regional findings that we included in the first one. The last update that I have for you all is that CHIA continues to support the partnership that we have with EHS to support its AHEM related data and analytics initiatives. And we also continue to support Mass Health's 1115 waiver by continuing the data collection of demographic information from hospitals' EHRs. Thank you.
Pardon me, what is AHEM?
AHEM is Advancing Health Equity in Massachusetts. And it is one of the sort of Commonwealth's initiatives to bring together, I think, a lot of different agencies within the state to tackle issues related to health equity. And CHIA has been a participant in that work.
It's too bad Eliza's not here. She's leading kind of the ops team on AHEM, and my organization is funding one of the local AHEM initiatives. And so on that point, I was actually wondering if there are opportunities for the CHIA team to share data and analytics with these various AHEM communities. They are place-based initiatives looking to implement community-driven strategies to address health equity. And I think it would be really helpful for them to have access to kind of the data that you have.
I love it. I love it.
Love to see it used.
Would you say 10 words about the 1115 equity program?
Sure. I think that was a Mass Health initiative to collect similar data elements that we're looking to collect in this new APCD member simplified file. So race, ethnicity, language, disability, sexual orientation, gender identity, specifically from hospitals and ACOs that might have that information within their EHR systems on the patient population that they see. And so given CHIA's experience, I think, collecting case mix information from acute care hospitals, CHIA has helped Mass Health in the sort of intake of that information to be able to deliver it back to Mass Health to sort of meet the requirements for that waiver. Yeah, of course. The next update that I have for you is about workforce. We have a couple of different updates for you all. I'll start first with what we're calling the Integrated Nursing Dashboard. This is a new work that CHIA is undertaking as a result of ongoing collaboration with the Massachusetts Department of Public Health and EHS to continue to monitor the healthcare space and workforce trends that help inform state policies and programs that are critical to ensuring residents' healthcare needs are met. The data in this dashboard is pulled from a number of different sources and is meant to describe the current landscape of nursing in Massachusetts. Some of the data sources that we're leveraging to do this are our own Massachusetts Healthcare and Human Services Workforce Survey, in addition to some other resources from our partners at DPH, some of their nursing relicensure survey data, the Department of Economic Research, some of the aggregate occupation-specific wage and BLS tables that they upkeep, and some information from the Board of Registration and Nursing regarding sort of pipeline issues, the number of nursing programs and graduation information specifically. And so that all of that data will be sort of aggregated to comment on characteristics about practicing RNs and LPNs in the state, where they practice, their future career intentions. It will aggregate some recruitment and retention struggles faced by healthcare and human service sectors, and it will include compensation trends and that nursing pipeline information. This dashboard is currently scheduled for release in early 2026. And we're hoping that this is useful to the folks tackling this issue of workforce. Another initiative that CHIA is working on is the second fielding of the Massachusetts Healthcare and Human Services Workforce Survey. That survey was fielded from February to August 2025 across 13 different healthcare and human service sectors. And as Lauren mentioned earlier, that survey is really fielded on the demand side to healthcare and human service organizations, to HR and administrators to sort of comment on their workforce in particular occupations. Since the survey's closure earlier this year, the data has been cleaned, weighted, and prepared for analysis. And right now we're in the midst of conducting some of our sector-specific analyses and cross-sector analyses through the end of this year to prepare for that publication. The final full dashboard containing the 2025 information from that survey is also going to be released in early 2026. And we are very much looking forward to that. Yes.
Would it be possible to say much about what it looks like the ongoing high vacancy rates of nursing home workers?
Yeah, that's a great question. So nursing homes is one of the sectors that we fielded this survey in, and we do present vacancy turnover information about select occupations in the nursing home sector.
CNAs in particular.
Yeah, direct care workers is sort of the blanket term that's used for in the nursing home sector, in addition to other occupations like registered nurses, activity staff, dietary staff. So yes, that will be included in 2025 survey results.
Are there, within the, sorry, if you can go back a slide, for the integrated nursing dashboard, is there a differentiation between like inpatient and outpatient with that data? Like like the setting in which they're working?
Yeah, so practice setting is something that will be included in that dashboard for RNs and LPNs. That data is available through some information that DPH collects as part of the relicensure survey that they field, and that will be in there. Thank you. Lastly, I wanted to give you an update on another third initiative that CHIA is undertaking as part of its sort of workforce portfolio, and that is our employee voice study. This effort is sort of a complement to our workforce survey that is focused on collecting demand side information from healthcare and human service organizations. This employee voice survey would collect employee perspectives to better understand issues of recruitment and retention challenges that can influence individuals' decisions to work in healthcare, assess the effectiveness of organizational strategies from the perspective of the worker, and to examine how state policies might be encouraging workforce stability. This study will be a qualitative one, and so we'll be collecting data using focus groups with direct care workers and case managers who work in or have worked in post-acute care settings, such as home health care or long-term care facilities. This work just kicked off on December 1st. And so we are working closely with our vendor to design recruit participants for this focus group and actually conduct those focus groups and analyses. We are in the process of developing a detailed sampling strategy that is meant to be representative of gender, race, ethnicity, to be culturally inclusive, and offer groups to be moderated in a number of different languages. I think one thing that we're sure of is that we'll have to sort of oversample to combat attrition specifically for this type of study. And so we're working on developing the specifics to really get this off the ground. As part of this work, we plan to engage robustly with stakeholders who can help us recruit participants for this work, or who might have valuable insights to help us develop a really strong discussion guide, who might be able to help us contextualize some of the results that we end up getting as a result of this data collection. It's our intention that fieldwork will begin in early 2026, and we anticipate completing the analysis by summer of 2026.
Stakeholders to boost engagement and response rates. What's the spectrum of?
Yeah, I think at this stage, we're thinking about, we've put in a lot of work with provider associations as a result of our Massachusetts Healthcare and Human Services Workforce Survey. We worked very closely with them to identify sample lists for that survey. And I think we're looking to those folks to sort of help us think about how to also recruit in this space. But I think also we want to have folks at the table who, can really contribute meaningfully to this. So if there are any other recommendations of folks we should talk to. Yeah. Yes, that's correct. Sorry.
Mass Senior Care as the trade association, and then 1199, the union that predominantly is organized.
This is a new topic for us.
That's correct.
And it's 10 minutes of 4. So I would like everyone in the council to think about it. And please feel free to email you with thoughts, and then we'll have a little more conversation at our next meeting.
Sounds good.
Thank you.
Because I want to make sure we get time to the employer survey, which is also going out. They are also a stressed group.
Hello. I'm Hong Tru, Senior Director of Research at CHIA. And I'm just going to give a quick update about our Massachusetts Employer Survey. This is an ongoing biannual survey that CHIA does with employers that monitors and tracks employer health insurance offerings, employee take-up rates, cost sharing, plan characteristics, and employer decision-making. Since the fall, we've been reaching out to sister agencies and employer association on content priorities for 2026 survey cycle, or in the process of finalizing that. Going into the early part of this year, the survey will be tested and the scheduled launch date is in February 2026. Some of the key survey refinements that we're doing for 2026 include some of the enhanced granularity by employer sizes, separating out the merged market and small employers from the medium and large employers that's subject to the ACA mandates, Some new topics that surfaced for the 2026 cycles are some of the impacts on rising premiums on decision-making, some of the reasons that employers choosing to self-insure, also in terms of what is the prevalence of direct contracting with PBMs, and also use of PEOs for health benefits, and also the offering of direct primary care membership and access will also be included.
What's PEO?
It stands for Professional Employer Organizations. So an example of that would be ADP.
So which is an example?
ADP, like the payroll service, the HR payroll service. So it's an interesting arrangement where firms will go into a co-employment relationship with PEOs. And under this arrangement, the firm will continue to kind of manage the responsibility, what the employee does, but actually is the PEO who are actually hiring the employees and acts as the employer for insurance benefits. So it had came up in a couple conversations we had with interest holders that they were curious about the uptake of this type of arrangement.
Where they're using it for health. Used to pay and other benefits.
Yes.
Thank you, Beth. Ask a question.
I'm curious if this survey includes a question about percentage of employees on mass health. And also if there's a way to assess whether some employers are intentionally limiting the number of hours such that they don't have to provide health insurance. There was a Globe article recently, capping hours just under, the threshold. I'm not sure that you'll get an honest response, but if it's anonymous, it would be really interesting to see for how many employers is that a factor because they simply can't afford to pay health insurance.
I'll answer your first question is that, because this survey is for private employers, that's with 3 employees plus, and it's from an HR perspective. So it's very hard for an HR director to know if my employee refuses insurance, they're choosing not to enroll, where are they going? Because that's not a conversation that would happen at the HR office usually, and maybe in a coffee room conversation, but it's hard to quantify that on the survey. On the second part about, you have to remind me again.
Sort of keeping employees part-time.
Part-time. I think we do have measure about do they offer to part-time employees, and we do provide kind of like what is the minimum hours that are required to do that. One question that we do have towards the end is to almost like cost control measure in terms of do they kind of like basically hire more contract workers, or do they, that is one of the kind of options they could pick. But we currently do not have a question that directly asks, so are you capping hours? I think it'll be hard to miss that.
I was simply saying what percentage of your workforce part-time versus the last survey?
I don't have it off the top of my head right now, but we can provide that information later.
Yeah, because I think we're seeing more and more of that, and it undermines, kind of this whole system, this whole complex ecosystem of individual and employer mandates, and I think because it's changing over time, it would be interesting to capture.
I'm also curious about the reverse, with connector changes and specifically folks dropping off of the connector next year. If we're looking at employers actually picking up some individuals.
I think we're excited to find out.
Is there
that through this?
Is there any question relating to stop loss insurance?
I have to check on that. I know we have a definition for it, but I think it's more kind of like, please exclude stop loss insurance from your idea of offering insurance.
Would you include it with self-insuring? And most small companies, it's self-insured by some sort of stop loss.
Yeah, they do. I'd just be curious to know kind of a little bit more of the details on what type of stop loss insurance they're getting.
You mean like individual case versus aggregate versus?
Yeah.
We can check. We did try to sort of expand and refine some of our questions around the self-insured market because we know that more employers, for better or for worse, are moving in that direction. So we can double check on if we get to that level of specificity asking around stop loss.
Would the DOI know that because as more people turn to self-insurance, they don't have to pay the premium tax?
Say that one more time.
Would the DOI know that? As more people self-insure, one of the reasons is to get rid of the, not have to pay a premium tax. So is the money-
I don't know off the top of my head the answer to that question, but one of the concerns is that with the changes going on federally, there might be a shift also with folks with small employers having folks go on to the connector to avoid issues around stop loss insurance. So I don't know. I think just understanding a little bit more of kind of to what level of specificity would be really helpful.
Does direct contracting with PBMs refer to a pharma carve-out where the PBM is paid a lump sum to cover all drug costs? And like behavioral health carve-outs?
I think that's the intention, but I need to go back and see what the definition that we're
Thank you.
providing.
It may not be, you can carve it out because you pick the PBM you want instead of what your insurance is offering. I'm not sure it's self-insured versus non-self. And I think it'd be an interesting question as we think about PBMs.
That may mean
I might,
a variety of prices possible.
yeah.
Yeah.
All right, we have 2 minutes.
Just quickly related to the questions about the connector, do you ask any questions about ICRA's health reimbursement arrangements? Okay.
Me too.
Okay, that's great. So this is a survey we've been doing for some period of time, so it's nice to be able to add new and still look at how it's changed over time. So thank you for doing this. Is there any other closing comment in the next 2 minutes? Terrific. I wish everybody a very happy holiday season. And I can't wait to see everybody next year. And we have a very full agenda in 26. And thank you to the staff. You've done a great job this year. It was powerful. And we appreciate all the presenters. I know sometimes it's a pain in the neck, but it's really great. Yeah. Great job. Thank you. Thank you.
Thank you for astonishing